Osteogenesis imperfecta, we talk about this one briefly. It's not super common with this one, but NCLEX loves to test on it, and it's kind of goes hand in hand with some of the child abuse stuff. But basically, this is a connective tissue disorder, and you get bone fragility and bone defects. So some of the things that you're going to see is people get fractures all the time. And for things that you wouldn't think there'd be enough force to cause fractures. And so multiple fractures within the year are a big telltale sign of this. Other things you can see is that they've got hyperextensibility of the ligaments. And then what you can also see is a ballooning of the sclera. Leg calf Perthes disease. So this is a self-limited idiopathic disease that affects juveniles, and it's usually more common in males that are obese. But basically you get vascular necrosis of that femoral head. So it's not getting blood flow. And in that case, you're seeing that they can pop out of that acetabulum more and even lead into fractures. 10% of the cases are bilaterally, so not real common, but there is potential. And then most have delayed bone age with this, meaning that their bones just are not as strong as what they should be. Big things what we do is just try and keep them from running, jumping, climbing trees, keeping the head of the femur into that acetabulum and trying to prevent dislocations. And then so no weight bearing. Some people say they can have some walking privileges, but definitely, not playing tackle football or anything. Surgery is an option, but it's rarely used. Skiffy or slip calf femoral epiphysis. So the way that I was always told to look at this was, imagine that the ice cream cone is coming off the head, the ice cream's falling off the cone. So if you look at the bone here, this is your head, femoral head, into your socket, and you're just seeing it at this epiphyseal, and it's just become undone. So what you're kind of seeing with this one is, ages 10 to 16, there can be bilateral involvement with this one. But the big treatment for this is going to be surgery, in which they put a screw in, and they just hold that in place. Scoliosis is a very common finding in kids. We used to check for it all the time. We're doing less of that now, but we are still looking at this, and this is one of the more common things in childhood. So things that we can do is we look at spine deformities. This is the bend over, touch your feet. You're looking at things such as their hip height, and you're looking at the iliac crest to make sure that they're even on bilaterally. You're looking at the curvature of the spine and seeing if there's deviation to one side or the other one. Looking at their ribs and making sure that they're symmetric. So treatment of this, it's really a team approach. You're using ortho with this, as well as family practice, as well as PT. And a lot of it is bracing and exercise. So bracing, what we really try to do is get these TSLO braces. This one is kind of fun because it's an animal print. But a lot of times what they look like is they're white. And most children are not smiling. Most teenagers and most people I know that get put in these are not happy about it. And the reason why is because even though they put holes in it, it is hot and it's hard and it's uncomfortable and it makes them feel weird and they can't bend over and it causes lots of problems. And they can even get some digging in. So make sure that's fitting good. Make sure that you don't have rubbing underneath or up at where you're more mobile. So like in the shoulder regions, I've seen abrasions and skin breakdown. So these girls are smiling. Most are not. It is a little bit more common in females than it is in males. So if this doesn't work, and this is your better bet, but if this doesn't work, then you have to go into surgery. And then what you're doing is you're taking and putting rods in the back, so usually titanium rods, and then using specialized screws to screw right into the vertebral body to straighten that. One thing I want you to consider with this one is if this is your before and you're looking to see how far that this has come and you change it into being a straight like this and quote unquote being normal, you have to realize that internally this is going to shift your organs and that this person was used to having stuff like this, and you're resetting their organs, and sometimes they have complications with that. Also, anytime you're working with the spine, you do run the risk of having SI-ADH because of the nerve and involvement with this. So SI-ADH is a huge concern after any spinal surgery. Osteomyelitis, so this is infection of the bone. So oftentimes we get some seeding from somehow, some way. I've commonly seen Staph aureus. It could be a variety of things, but usually Staph or, in the methicillin resistant, so MRSA. This can be caused by trauma. So I've seen it caused by, there's a little boy I remember one time, and they were playing soccer with cleats on, and he got cleated. And that was an opening big enough for an infection to get seeded into his bone. It could be from open fractures. It could be, systemic from a sepsis, blood type of thing that they got from upper respiratory or some kind of a cough and cold. So early x-ray films can be misleading, is that they don't have a lot of destruction in them yet, so they might appear normal. But you got to do some serial scans of this. If this becomes positive, and they do have this, basically you're going to have antibiotics for a long period of time. And IV antibiotics are a better bet than oral, just because you get more absorption into that bone. And bone is a difficult place to get absorption into. So it's usually a prolonged treatment. 3 weeks, and I think that's on the short side. I've usually seen like 3 months to 6 months. And so PICC lines, are very beneficial with this. The other nice thing is with the PICC line, they can go home. They can do some of the antibiotics at home then. So things that we got to monitor then. So looking at the heme status, if you're affecting the bone, is that bone able to produce hemoglobin? And then, of course, renal components with this from the calcium. Looking at hepatic responses to treatment from the antibiotics. So, sometimes we do have to do surgery to do open reductions, debridements, and oftentimes they'll instill antibiotic right into that bone marrow then. Septic arthritis. So one of the big things that we look for is a joint that's warm, tender, red, swollen, and painful. And this is unilateral. So it's not common to have this in a bilateral type of thing. If it's bilateral, then oftentimes we're looking for something else. This can often follow like a traumatic injury from like a fall, and getting some compression at the knee joint. But you're going to see fever, leukocytosis, and increased sed rate. In teenagers or people that are actively having sex, Neisseria gonorrhea can be a cause of this. So treatment, of course, then would be with this, specifically geared towards Neisseria. Otherwise, this could be used for any type of septic arthritis, especially if we're thinking like it's Staph aureus or MRSA. So tumors, so osteosarcomas and Ewing sarcomas are 85% of all malignant bone tumors in kids. They commonly occur more in males, but especially during adolescence. So that peak time is 15 to 19 months old. Treatment of bone tumors is surgery and then chemotherapy and or radiation. So it really kind of depends on what tumor that they have and how widespread it is. GIA, this used to be called JRA, but this is now the appropriate term. Otherwise, it can also be called idiopathic arthritis of childhood. And so this is an autoimmune disease where your body attacks itself. Oftentimes we think that there's some kind of a trigger, such as a cold or a common virus, that causes the body to kind of go into overload, into overtime. Peak onset is 1 to 3 years, but often this is diagnosed much later in life because this is very hard to diagnose. Multiple people have got multiple hospitalizations and multiple times that they're seen by a provider, because it kind of comes and goes, and it can shift from joints to joints, and so it's very hard to diagnose. So it's kind of non-specific things. But treatment can include non-steroidal anti-inflammatory drugs, so your NSAIDs, anti-rheumatic drugs, cortisol, cytotoxic agents, and immunomodulators. Basically, you're really just trying to calm that body down with all of these and trying to stop it from attacking itself. Other management, so basically physical therapy, occupational therapy, depending on where these are happening and what joints that they affect. Pain relief, of course, using some of your NSAIDs. This can also be using hot or cold therapeutic, thermal modalities, so ice packs, heat packs, those kind of things. And just trying to get them to be active as much as possible, but probably not having them run, jog, do things that have got a lot of compression on those joints. Like I said, encourage exercise, and then, of course, support children and family. All right, lupus, SLE. This is, again, another autoimmune disease. Affects connective tissues. It's characterized by inflammation. More common in females, often happens initially when they're teenagers. Happens in African American, Asian, Hispanic children, but by all means can happen in Caucasian as well. Symptoms are variable. The pathognomonic thing is this butterfly rash here, where you get it across the cheeks bilaterally. And so it can even go up into the forehead, but probably commonly I've heard it just right below the eyes. So you can get cutaneous lesions. This can be, just because they've got a rash on their face, doesn't mean that it doesn't go anywhere else. And oftentimes where we see it are in places that are very vascular. So kidneys are one of the big things that we worry about. The other thing is that it can go into your lungs as well, because once again, that's a very vascular aspect of your body. Goals of treatment, supportive care, pharmacology. We can use steroids, we can use antimalarials, which I thought was kind of an interesting thing. We can use NSAIDs, we can use immunosuppressive agents, and we can use antihypertensives to manage some of the blood pressure issues. Can also use light, and so exposure to UVB light I thought was kind of an interesting treatment modality, but that does seem to help. Minimize exacerbations, allowing them to sleep, have good nutrition and exercise, and then try to make sure that they're compliant with this. Another major concern with that butterfly rash is that there's a lot of body image concerns. This is something that, people can see your face and people become very sensitive to. This concludes this module. If you have any questions with this, please contact me. And I hope you have a great day.